Good afternoon. I'm presenting to you on multidisciplinary goal setting in rehabilitation for stroke patients based on the International Classification of Functioning, Disability and Health. To start off with, I'd like to briefly outline the objectives of this presentation. You should gain a basic understanding of the relevance of the International Classification of Functioning, Disability and Health on clinical practice. Gain a basic understanding of the multidisciplinary goal setting process, and gain an understanding of structures used for setting goals. The outline of the presentation is that firstly I will describe a bit of the background of the ICF. There's a brief outline of the need for a multidisciplinary team in stroke rehabilitation. There will be an introduction on goal setting in stroke patients, and then there will be some examples of practical implementation of goal setting and ICF-based assessments. All of this will be in the context of some insights into supporting evidence for the structure and the information presented. What is the International Classification of Functioning, Disability and Health? It is part of a family of international classifications developed by the World Health Organization. Other members of this family include the International Classification of Disease, which is now into its 11th revision, and the International Classification of Health Interventions. The ICF is a revision of the International Classification of Impairments, Disabilities and Handicaps, the ICIDH, which was first published in 1980 and was the first classification looking at the effects of disease and other contributors to physical disability and impairments. The ICF was approved by the WHO Executive Board in December 2000 and by the World Assembly of the WHO in 2001. It was designed as a multi-purpose tool to be used in the clinical setting, for research, for educational purposes, as a statistical tool, and as a tool to be able to develop and quantify disability for social policy. The role of the ICF is that it is to establish a common language between different professionals, different stakeholders, which include patients, caregivers, administrative staff, health policy staff, service providers, funders, researchers, and many others, and also to serve as a basis for a shared documentation system. This slide highlights the interaction between a health condition, environmental factors, personal factors, and the individual, including their body functions and structures, and the activity and participation that an individual can undertake. It helps us to understand that our activities and our participation are multifactorial and are part of a complex interaction of an individual in their environment. What is the ICF for? It is an attempt for us to comprehensively understand functioning and disability in persons with health conditions, independent of their health condition, the etiology, the cultural background, and other factors which affect their functioning and disability. It is to be used to allow data collection for comparison about functioning in persons with the same health conditions across various populations in different countries, with different cultures, with different backgrounds, etc. And the aim is to stimulate the development of services to increase levels of social participation among people with disabilities. The ICF is divided into several components: body functions and structures, activities and participation, and environmental factors. Altogether, there are over 1,400 categories in the ICF. The chapters on body function and body structures each contain 8 chapters, which are roughly in parallel, representing the mental functions or nervous system, the sensory functions and pain, voice and speech functions, cardiovascular, hematological, immunological, and respiratory systems, functions of the digestive, metabolic, and endocrine systems, genitourinary and reproductive functions, neuromuscular and movement-related functions, and functions of the skin and related structures. In the component of functioning and disability, the ICF groups activity and participation together and has broad definitions for activity as the execution of a task or action by an individual, which represents the individual's perspective of functioning, and the participation component is defined as the involvement in a life situation, representing a more community perspective of functioning. The ICF introduced environmental factors as a significant and relevant factor in the performance and activity of an individual with a disability, and has established the interrelationship between the availability of products and technology, the natural environment, and human-made changes to the environment, the support and relationships and the attitudes of individuals with which one deals, as well as the services, systems, and policies available, that each of these has an impact on the activity and participation an individual with a disability can undertake. The ICF also has qualifiers which quantify the degree of difficulty one may have with a particular category, where 0 signifies no problem. In other words, it is the highest level of function. 1 signifies a mild problem, 2 a moderate problem, 3 a severe problem, and 4 a complete problem or a total inability with a particular activity or participation. It is acknowledged that environmental factors may either be barriers, in which case they make it more difficult. So we use the same qualifiers, but for barriers, because they make it more difficult, we use a minus in front of the qualifier. Or if it is a facilitator and enables the individual or makes it easier to do a task, we use a sign plus to indicate that it assists in alleviating the challenge with the task or body function or structure. Let's now move on to multidisciplinary care. And firstly, some background information. As you're well aware, following a stroke, there is a wide variety of clinical signs and symptoms and associated activity and participation limitations and restrictions. This complexity of signs, symptoms, and limitations and restrictions is best treated with an interdisciplinary team approach with different professionals, each one with their own area of expertise, working together cohesively to implement an effective stroke rehabilitation program. Stroke patients, like many other patients with chronic health conditions, are in special need of continuous care, requiring longitudinal, integrated and multidisciplinary networks to link health and social care. There is a high level of evidence on the benefits of acute stroke care in reducing deaths, institutionalization or dependency for patients who have had a stroke. There is moderate confidence evidence that integrated multidisciplinary care teams improve stroke outcomes. It appears that coordination and cooperation of the team and the team members are the key factors for achieving the improved outcomes. The contributors to these outcomes seem to be predominantly early diagnosis, early coordinated treatment, early and coordinated rehabilitation. Rehabilitation treatment needs to be individualized. Each age group, each stage of the disease, each individual has specific needs that need to be addressed in the care process. These include biological, psychological, and social needs, and need to be adjusted according to the healthcare services available. Not only is a multidisciplinary team important, but also the coordination of the team. Team coordination is mainly done through multidisciplinary case conferences and meetings where patient goals are shared, discussed, and refined. There is a relationship between team processes, specifically in how the team deals with communication, with coordination, and their attitudes and perceptions, which are expressed by the members of the team, and patient outcomes. Patients had greater functional improvements if the team was more structured and there was a greater use of patient outcome data. A paper by Tyson has suggested some practical tips on having successful team meetings, which include preparation by all participants in the lead up to the meeting, having a set agenda, having a skilled chairperson, using structured documentation, and using standardized formal measurement tools. Implementing all of these components has resulted in a 5 to 58% improvement in the quality of the meetings without losing staff productivity, requiring further resources and importantly, it has also resulted in greater functional improvement of the patient. Here you can see a more complex table which shows the interrelationships and the conceptual framework for multidisciplinary team meetings in stroke rehabilitation, most of the components we have touched on. So let's now move on to the actual goal setting in rehabilitation. Firstly, a definition of rehabilitation goal. This refers to a desired future state to be achieved by a person with a disability as a result of rehabilitation activities. Rehabilitation goals are actively selected, intentionally created, they have a purpose, and are shared wherever possible by the people participating in the activities and intervention designed to address the consequences of the acquired disability. Scientifically, there is low to moderate evidence on the effectiveness of goal setting, and the evaluation of psychosocial factors such as health-related quality of life, emotional status, and self-efficacy is available. Nonetheless, goal setting is a core process in managing complex situations which are challenging for service providers in providing daily routine therapy. There is no universal agreement on the standards and definition of goal setting or on their evaluation. And further studies and evaluation are required to clarify the types of goals, number of goals, the impact of patient involvement in the goal setting, the evaluation process, the influence of goal attainment on adherence to a structured rehabilitation program, the self-efficacy and health-related quality of life related to goals. The process of goal setting itself is considered to be the establishment or negotiation of rehabilitation goals and will be considered synonymously or at the same time with goal planning. So you set the goals and you also plan how to attain the goals, and we'll come back to that in a little more detail in a moment. Goal setting in rehabilitation has long been recommended in both organisational and professional guidelines, and there is a consensus that person-centred goal setting is paramount for rehabilitation services. Clients have reported that they feel more involved and have a better understanding of the rehabilitation process when they are consulted and involved in the goal setting process. I stress this point again because it is really fundamental. The goals belong to the patient, not the clinician. When goals reflect the patient's priorities, they describe their desired level of achievement and are relevant to their life roles and their situation. Goals can be classified by the type of activity or an aspect of participation that they relate to, but they should not be classified by a particular therapy or discipline. Patient priorities need to drive their own requirements, their lifestyle and context in which they live. The rehabilitation program, including therapy interventions and goals, while important, is only a means to help patients achieve their priorities. Let us now focus on barriers, or things which make it more difficult, and facilitators, or things which make it easier to set goals. Barriers to goal setting during the stroke rehabilitation program include a mismatch between patients and staff's perspectives and expectations. The knowledge base of a health professional is different to that of a patient. And so sometimes as a health professional, we may think that a patient has an unrealistic or an unachievable goal. And this is a mismatch between our perspectives and their perspectives. If we are confident in our understanding, in our knowledge and experienced in the treatment of patients, we can often explain to patients that at the moment such a goal is not achievable. For example, a patient who is unable to stand is not able to learn to run immediately, although it may or may not be possible to do that in the distant future. If we can explain that, then we often are able to minimize or even eliminate the mismatch between our perspective and the patient's perspective. The severity of the patient's stroke-related impairments may make it difficult for us to set realistic goals, but often all we need to do is to simplify the goals and make them at a level which the patient can achieve. Sometimes we feel that there is a lack of time and we're under time pressure, so that we don't have sufficient time to discuss the matters with our patients, and that may indeed be correct. However, often we end up having to spend more time further down the track explaining to patients and regaining their confidence. So it is worthwhile investing time early on. Facilitators are early, frequent, active communication with the patient and their family so that we can align our expectations to their expectations and their expectations to our expectations. That we individually tailor the goals and the process to the patient. There is no prescribed formula of goals for all patients. That we are effective, confident, and encouraging of the patient, and that we ourselves are confident in our ability to handle this process. That we educate the patients and their families, and that we provide support and educational materials and adequate resources for the patients and their family. When planned in the study which presents this information, analysed all this, they came up to the conclusion that the current methods of goal setting during stroke rehabilitation are not fit for purpose, and that we have to do better and that we can do better. A Cochrane review on goal setting and strategies showed that there were 12 different approaches to goal setting. Each had their variations in goal identification, goal selection, goal prioritization, goal characteristics, and the use of intervention, planning, etc. But there were two common features across these different approaches, and those two were having measurable goals, in other words, having goals which you can measure and you can clearly demonstrate achievement and progress, and having patients involved in the goal setting process. There was low evidence, but nonetheless there was evidence that such programs increased health-related quality of life, self-reported emotional status, in other words, that we feel better about ourselves or the patient feel better about themselves, and self-efficacy when there was some form of goal setting compared to no goal setting. There is no consistent evidence that goal setting impacts on the impairments themselves. So let's briefly look at the philosophy of setting goals. Setting goals give a common language and a common setting of goals and objectives and what we are trying to do together with our patients. They share the vision. They allow us to publicize and communicate the vision between the team members and the patient, but also with the patient's families and their carers. They can be used to motivate to achievement, and they can provide a roadmap to success, demonstrating a step-by-step process to ultimately achieving a good functional outcome. This brings us to the last section of this presentation, the actual practical guide to setting goals. A good acronym for setting goals are PC, SMART, AAR goals. I already talked about the goals needing to be patient-centered, and I'll reiterate this again. This is essential for good patient outcomes. Now let's look at the SMART components: specific, measurable, achievable, relevant, and time-bound. Specific goals refers to the goals which are specific and maybe unique to the patient's situation, to the patient's desired outcome. Specific also means that they are well described so that it's easy to identify and communicate what we are trying to achieve. They need to be specific and detailed to allow tracking against progress towards a bigger goal or an overall endpoint on achievement. They need to describe concrete outcomes. Generally, we should phrase them in short sentences. In other words, we should be succinct. Relevant background information and factors which can influence the outcomes may have to be included, and environmental or assistive technology which is required may need to be included, and relevant contextual information, e.g. the need to walk on uneven terrain, should also be included. So specific has multiple components. Then they need to be measurable. The point of achievement must be able to be identified. The goal may need to include parameters, including the frequency of a task or a goal or a therapy intervention, the intensity, so how long you have to undertake a therapy session or a task, the time required to perform the task, the assistance level required, and the quality of the activity may need to be considered as well. So each of those components are measurable and can be quantified when setting the goal. Patient goals should be achievable. This can also be termed as realistic, although even if apparently unrealistic, patient goals may be used to set intermediate achievable goals to motivate the patient. But even if realistic, sometimes the overall goal needs to be broken down into sub-goals. Environmental interventions may be required to make the goals achievable, and this needs to be acknowledged. The goals should be sufficiently challenging, however, so that they motivate the patient. And they should take into account that there may be different timeframes for their achievement. If one is unable to agree with the patient on achievable patient-generated goals, one may need to substitute patient-focused goals. In other words, we look at what the patient can do and what they are generally aiming for, but we set the goals for them if we cannot, because of particularly cognitive deficits, agree on an achievable goal. Sometimes it may be appropriate to use a combination of patient-generated and patient-focused goals. But in all matters, not only the patient, but their carers and family should also be included. Patient goals need to be relevant to their needs, and this relevance increases their motivation and increases the chance of success. The goals need to be time-bound. A realistic time period should be set to achieve the goals. An expected date of achievement will help focus on goal achievement. Each goal will have its own time frame, and the time frame needs to be reassessed as the conditions change. Now we come to the AAR of the goals. An action plan should accompany each goal. It should outline the process of how to achieve the goal and may include required patient actions, actions required from clinicians, actions required from families and carers. It may include several steps in the process and progress towards the goal. Then we should have an achievement rating. We should measure the goal achievement. Progress towards the achievement should be measured and reported, including the achievement of the goals themselves, the achievement of any intermediate steps, the achievement of the action plan, and if there is little or no progress, reason for not progressing should be recorded. Recorded patient's progress can then be used as an outcome measure. There are multiple ways to score achievement, which go beyond this presentation. Finally, we need to report on the goal outcomes. Patient progress on goal achievement needs to be communicated to the patient, families and the carers, to all members relevant in the multidisciplinary team, to any other stakeholders such as fund holders, so that we can continue therapy, and it can be used as part of a benchmarking progress to compare the rehabilitation program which we provide to other rehabilitation programs. So finally, let us look at some practical examples of goals. This slide summarizes in a flow chart the steps you would go through in the goal setting process in rehabilitation. We've gone through these steps over the last half an hour or so I won't repeat them all, but it's a good summary which you might want to use. And this is a worksheet which you could use to write in the goals as well as goal elements as you set your SMART goals. Both the previous slide and this slide are from the ACI reference, which you might want to look at on their website. One way of setting goals could be to use an ICF-based goal setting table, and you could either use categories from the ICF itself, or you could use one of the core sets, and we'll go through some more information on the core sets in a minute. This one is out of reference from Leonardi in 2021 using self-care activities, and then you can describe the goals and describe the context as well as actually measuring the goals. And this is the final slide. These kind of score sheets are available from the ICF research branch, which is referenced in next 2 slides. It has a assessment sheet with the ICF categories. You can put in the initial score, the goal of what they want to achieve, the goal value of where they want to go, and then you can do a progress evaluation and demonstrate it visually. You can do this as a computerized file, which makes it easy to enter the data and to compare and monitor progress. These are the references. Again, worthwhile looking at some of those references, particularly the ICF research branch and the rehabilitation goal training from the ACI, or the Agency for Clinical Innovation. The material for both of those is available freely for download and for use, and the rest of the references. I thank you very much for your attention, and I think there's time for a few questions if anybody has any questions. I wish you all the best as you apply these in your clinical practice.